Hello, welcome to Aspen's Nutrition Nexus Live. Today's program is titled Beyond the Diagnosis, Supporting Quality of Life in SBS Through Multidisciplinary Care. My name is Kelly Kinnair from Aspen, and today we are honored to have with us Dr. David Mercer and Marie Neumann. Dr. Mercer is the director of the Intestinal Rehabilitation Program and professor of surgery in the Division of Transplant Surgery at the University of Nebraska Medical Center. And Marie Neumann is a researcher at the University of Nebraska Medical Center who has been conducting research on quality of life in patients with short bowel syndrome and their families. Today's program has been supported by Zealand. Your questions may be submitted at any time using the Q&A function at the bottom of your webinar player. And today's speakers will address your questions at the end of their presentation. I would now like to welcome Dr. David Mercer and Marie Neumann. Thank you for being here with us today.
Hi, Kelly. Thank you very much for having us, and thanks to everybody for taking time out of your day to come and hear what what we have to say. I'm just going to preface things a little bit by saying, Marie and I have not scripted anything in advance, so we've talked over a little bit about what the questions might be, but what you're really going to see is just our unscripted discussion back and forth with Kelly about some of these different issues, and I think an opportunity for everyone to answer or ask questions towards the end of things. And I think we'll try to give you the most honest and sort of heartfelt answers that we can about how we do things. Marie, do you have a little bit that you want to add before we get started?
I don't know if I have anything to add. I guess maybe I will add that in addition to having conducted research on quality of life the last couple of years, I am also the mother of a little kiddo with short bowel syndrome. So all of my perspectives that I'm sharing today are shaped both by my personal experience and also by the work that I've done the last few years to better understand these issues.
And I didn't sort of want to lead in with that, everyone, but you're going to see how that has really shaped the way that we provide care. And I think that you hopefully all come to appreciate the very special, unique, and wonderful relationship that Marie and I have developed over the past few years and the influence that that's had on our team and directly on the way that we provide care. So Kelly, I'll turn it over to you if you want to start sort of leading off, and we'll get into it.
Absolutely. Yes. Thank you for those additions too. So I think we'll just dig right in. I mean, right, we're here to talk about quality of life in patients with short bowel syndrome. So I really kind of want to kick it off to you guys by asking, what are the factors that contribute to quality of life in a patient with SBS? So specifically patient, but also what about the caregiver? What are the challenges or factors that contribute to their quality of life as well?
I think I'll get us started off here. So for me, again, as a mom, but also as someone who's been conducting research for the last few years on exactly this topic, the biggest takeaway really has been that these factors that shape quality of life for patients and also their families really extend far beyond the clinical realm, right? So quality of life, we know, is a really complex and subjective construct. I like to imagine it kind of like an ecosystem, right? So there are lots of interacting parts, and this ecosystem really functions best when there's a balance between all of the different parts, right? And so health is really just one component of this really complex system. And there are a lot of other factors that are equally important or maybe even more important to quality of life than health or these clinical factors that we traditionally think about, right? So other factors might be the social relationships that we have, or feeling a sense of control over our lives, or having a sense of purpose, or having a sense of autonomy. And so one of the quotes that I always return to actually comes from Dr. Marian Winkler's work. Of course, she's done a lot of work on quality of life of adult patients on home parenteral nutrition. And so one of the adult patients that she interviewed actually said that to them, quality of life means having the ability to do what you want to do when you want to do it. And then, of course, patients are really embedded in systems, right? One of those systems is the family. And so, especially in the pediatric context, we know that all of these multiple factors then extend to the family system. So when we're thinking about caregivers specifically, we should also be thinking about factors like, does the patient's treatment regimen, can that regimen be easily integrated into family routines, right? Or do parents have access to childcare or to respite care that they trust given the child's complex health needs? So again, for me, I think the biggest takeaway has been that quality of life is really complex and is determined by a lot of factors, many of which really extend beyond the patient's health and their clinical treatments.
Yeah, so I'll build off that a little bit. I think that in our work with Marie, it really has taught to us as a team how the issue is considerably more complex than what we originally envisioned. I'm going to preface our comments through all this by saying, so we look after children and adults, and so my practice is looking after both kids and adults. Marie tends to be more focused on the pediatric side of our program, but some of what we're saying, or much of what we're saying, I should say, it carries over directly onto both sides. There can be some unique circumstances in pediatrics versus adults where, for example, the care that's administered in a pediatric environment might have a larger impact on the whole family unit because it's taking time, a parent's time, perhaps to provide, TPN, get things set up, manage the things they have to do, which is then time that's taken away from other children in the family. That may not be the same circumstance, for example, in a household where there's two adults, one of whom has short bowel syndrome, and that person is perhaps largely self-sufficient. So there are quality of life issues that exist in each of those environments that they can be very nuanced and be very different. And I think that as we've looked at this, we talked, in your question, Kelly, about so what are the factors that relate to quality of life? It is really almost going back a step earlier, and as Marie was saying, sort of what is quality of life in the first place? Whenever we go to talk at one of our academic conferences or something like that, almost anyone who provides care in this field is going to go up and they're going to say, oh, we provide care in a multidisciplinary environment, right? We all say that all the time. And everybody puts up a PowerPoint slide. And on that PowerPoint slide, you see a physician and a nurse and a dietitian and a social worker. And then in the center, you have a patient. And we all say, well, we're really focused on, the patient is at the center of everything that we do. But I think one of the things I've come to realize is I think sometimes we talk the talk, but I'm not sure we always truly walk the walk. And what is going to come out, I think, over the subsequent 20 minutes of our talk is how if you truly, truly buy into actually integrating the patient into not in the center of the team where they're separate from the team, but actually physically become a part of the team, it's a different sort of thing. It isn't a group of people circulating around the outside of a patient with the patient at the middle. It's that the patient is part of the team, that the decision process directly, inherently involves them, that the decisions that you make are not, it isn't everyone else making decisions about what they think is best for that person and their quality of life. It's literally saying, we are going to choose decisions driven by what you perceive as your quality of life and how we can make that better. And that changes things. That is truly sort of walking the walk about patient-centered care. And I would like to think that that's something that we have really, really embraced and encompassed in our everyday life. I'll probably get into some examples of what that practically means as we get further on in the discussion. But Kelly, does that get you started on what you were thinking for answers to that first question?
Yeah, absolutely. And the slide you described, I can't tell you the number of times I've used a slide like that in a presentation. And if I were to give something again, I would absolutely change it and put that patient in the circle with the other providers. I mean, you gave me like a perfect visual of what that would look like. So thank you for that.
And in the end, what monomals do in that figure is put sort of the concept of quality of life in the center, right? And then all of these other things are working together, and the goal becomes quality of life. And one element of that goal could be making improvements in, TPN or enteral feeds or something. But in some cases, when you shift to a quality of life driven approach to care, sometimes it actually compels you to make decisions that are counterintuitive to what you might have made. I can tell you my entire practice is different as a result. I do things that in some cases are directly the opposite of what I would have done 10 years ago, or even 6 years ago, or 5 years ago, as a consequence of shifting to a quality of life centered model of care.
Great. So yeah, I guess I'd like to take the next step then and talk about, potentially what are some strategies for improvement then in quality of life in these patients. And maybe improvement isn't the word, maybe it's maintenance, right? If we think they're in a good place too, whatever that patient goal is. But can you talk through some strategies for our audience today?
Well, Marie, I'll start off with this, and then I might actually ask you a few questions. But so I keep harping on this idea of quality of life based decision making. So what does that actually mean in real life? Because for many patients, sometimes when you go to a place, maybe you come to see us for the first time, or somewhere else for the first time, and you come to a quality of life based environment, it can be almost a little bit disconcerting, because people are suddenly asking you things that are very, very different from what you're used to. And so in many cases, the least of our worries at any one time is, what are we actually doing with TPN and tube feeds? And what we're tending to do is sit down and sort of say, okay, so what's your day like? How's it going? And it can get into very, very simple things like, so how many of the kids do you have in the family? Who's in sports? What grades are they in? How often do you have to carpool? What time does everyone go to bed? What time does the bus get around in the morning to take people to school? Do you have to drop off? If you have to drop off, what's the order of drop off? What all is happening? Because you start to think about these very practical things. And I'm specifically talking about a pediatric example here because it'll be easier to segue to Marie. So when you start off looking at those things, and then that leads you into a very comfortable discussion sometimes with people about, well, what's good and what's bad about your day. And then sometimes people might say to you things that are very different from what you might have expected as to what is important to them. And I'm going to ask Marie to comment on this, because it teaches back towards her research and some of her findings. But so when the approach is to start off in, let's say you have 20 or 30 minutes in an office visit, really the decisions about what to do nutritionally, that might take us a minute. So we're spending 20 minutes or 25 minutes finding out, how's the family doing? How is everyone? How are the other ones? How are the little ones? How's maybe if it's a school age kid, how's that going? Are you embarrassed to have to use the bathroom at school? Do you get the ability to go to the nurse's office and have time to eat if you need to? Can you get access to hydration? Can you do all of these other things? And we spend all of the time actually gathering information about what are the factors that influence day-to-day quality of life. And then at the end, we really are sitting back with the dietitians, gastroenterologists, myself as a surgeon, parents, kids, everyone, and saying, okay, how does it sound? What about if we do this? Does this make your life better? And if it makes your life better, then that's what we should do. And then we should check up with you and say, is it better as a consequence of what we did or not? And if it isn't, then we should do something different. So Marie, from your perspective, both as a researcher and also as a recipient of this approach, what do you think? And everyone, I'll tell you, like, one of the things that's been very important to me about Marie's research is it's taught me that things that I would have thought were important to caregivers and to patients with short bowel syndrome, when we actually study them, I won't steal Marie's thunder other than to say I think it gives us some surprising insights into what's important. So Marie, would you take over for a bit?
Yeah, I mean, I guess the first thing that I will say just briefly is that I think from a clinician's perspective, it may sometimes feel unnatural to start talking about all of these non-clinical factors, right? Because you don't have that much control over them necessarily. You feel like maybe it doesn't fall into your realm. But I think it's so important to remember that the non-clinical and the clinical factors are so interrelated and interdependent on one another, right? So a perfect example of this is that you might have a patient who is on tube feeds or receiving parenteral nutrition, and the number of hours that they're connected or the volume that they're receiving is related to the quality of their sleep, right? And that then impacts the way they're able to function the next day at school or at work. And so you can see how all of these factors are connected to one another, right? We know that clinical outcomes are to a large degree dependent on people's social environments. And so it's really important to understand then the environment and the context that your patient is sort of functioning in. And so that's just my 2 cents on that. In terms of the clinician, Dave, the question that you had about sort of clinician assumptions or expectations on what matters to patients and families and what might actually matter to them. I think a good example of this is we conducted interviews with kids who had a history or who have short bowel syndrome. And in those interviews, one of the questions I would ask kids is, how do they feel about the way their condition impacts their family? And of course, we would all assume, right, that kids would think, man, the impact of my condition on my family is bad. Like we all have to, encounter all of these stressors, and my parents have to manage my medical needs. But this kid told me, you know what, I feel really good about the impact of my condition on my family. And I asked him, why is that? Explain that to me. And he said, every time we have to go to a clinic appointment, we travel to another city, and my family always does really fun things when we do that. And so to him, actually, the first thing he thought of is, I feel great about the way my condition impacts my family. And I think that gets back to what Dave is saying. It's really easy to make assumptions. It's maybe a little bit more challenging to come with a completely open mind and ask kids or adult patients and their families what matters to you and how does this impact your family. But we might come away with some really interesting findings and conclusions if we ask instead of assuming.
And I'm going to add one little thing on to my own part about how the flip to quality of life has changed my own decision making. Marie had alluded to the idea of like tube feed rates and TPN rates and stuff like that. One of the things that we realized was much more important than we appreciated was how much sleep caregivers were getting. And I think we all think about it, but we didn't make it a focus. And so if you were trying to spare TPN, you might say, okay, well, let's go up on feeds, right? We do a little more feeds, we don't have to do so much TPN, and that's a good thing. And sure, at some level it is. But if that then means that either as an adult, you're up 3 or 4 times at night every 2 hours because you're having a bowel movement, and maybe you're partly asleep, so when you wake up, you have a little bit of an accident, or you have a child who's having a blowout poop 3 times a night, and that's a set of sheets every single time, well, then you really haven't done a service to the quality of life of the family, because what you've really done is perhaps disrupted everyone's sleep. And we all know that it only takes a few nights of disrupted sleep before suddenly your cognitive performance goes down, your patience become thin. If you're the non-affected child in the family, now suddenly you're affected by a mom who might not have as much compassion or as much patience as she would otherwise. And so in the end, then you've sort of done a disservice to the quality of life of the whole family. And so if you would have asked young Dave Mercer what to do, I might have said, well, of course we want to come down on TPN and we want to go up on feeds. But now I might actually say, you know what? Well, let's just go back up on TPN a little bit and go down on feeds, because I think we all need to have better nights. We need to sleep more, and we need to make sure that everyone's getting 6 or 7 or 8 hours. And all of a sudden, we have a family that comes back in a month and goes, oh my gosh, we feel so much better. We're so much more compliant. Everything's going well. He's doing great at school. All the kids are happy. And I would argue that we've done a better service to that child and to their family than we would have by, getting feeds from 30 to 40 mils per hour.
Great. That I love the examples that you guys are providing too. It's just really helpful to kind of, right, you don't always think about the effect on the family. Like the caregiver sleep example is just so great. Like saying like, well, maybe now the patient is affected. just things that we don't think about where we have to really treat the whole picture here. So I guess, we've kind of gone over the importance of, the patient, or really the family, at the center of all of our decision making. So, and the, impact that all of these things can have on quality of life. Can you walk us through, some best practices for assessing quality of life, monitoring, right? So we make a change in the regimen, or we make a change in something. How are we following up to assess, rather than, maybe just subjective, feedback from the patient and family? What are some of the best practices for, again, monitoring, following up on quality of life, and even sort of developing some of these patient-centered goals that you guys are talking about?
Marie, I'm going to have you answer this, but I'm going to preface your answer just for 10 seconds, just to say historically, it would have been exactly what you just said, Kelly, which was just to be cognizant of it and to sort of follow up on your quality of life, and in a somewhat perhaps nebulous way, place quality of life at the center of what you do, and then just keep asking on it. But I think what Marie will address now is what we really think the future of this is. So Marie, maybe that'll be a good segue into you presenting stuff.
Yeah, sure. Thanks, Dave. So I think I think, Dave, I'll speak for you here too, but I think it's safe to say that both Dave and I believe that quality of life should be measured really just like any clinical indicator that is already assessed routinely, right? So we both really believe that patient quality of life should become part of decision making. And I also think it really needs to become one of the metrics of success, right? So currently, our only metric of success is whether a patient has achieved or has been weaned from intravenous nutrition. But I would really argue that that shouldn't really be the only metric that we use. So at our center, we started measuring quality of life of pediatric patients a few years ago using a tool that we actually specifically designed for this purpose. And the really cool thing about this tool is that it was actually developed by intestinal failure patients and parents themselves. So for the time being, this tool is being used largely for research purposes. So at the population level, to really help us identify what the determinants of quality of life are in this patient population. But there's also an opportunity to really integrate this tool into clinical care in the future, to really inform communication and really make the consideration of patient quality of life more systematic, right, Kelly, rather than something that you do sort of ad hoc and maybe one clinician does better than another clinician. Having an assessment tool that's integrated into the clinical workflow will really allow us to make the assessment of patient quality of life systematic across centers. And that's really going to change, I think, or we both think, the way that care is provided in this field.
So in effect, what we envision, Kelly, in the future is the idea that right now the way the tool works is it's a sort of a self-administered survey that can be done. Kids can do it, and parents can also do it on behalf of smaller children, done off an iPad. I think they find it very easy to do. In general, they enjoy doing it, and it probably takes at the most 10 minutes and probably less. And what we would like to see is something along the lines of when you come into a room, you have a growth chart, or you have, for adults, you have, height and weight, and you have a recent set of labs, but you also have a heat map of quality of life that shows you what are your greens and what are your reds, and was something green previously that is red now, or something is red that was green. And you can look over the heat map or something like that, and you can say, gee, I noticed that your work performance has been really good for the last 8 months, but all of a sudden, you're rating your work performance lower. Can you tell me, like, what's been going on? Is there something going on in the way we're providing care that can help to improve your work performance? And maybe that's, less volume during the day, so there's less bathroom breaks, or maybe, it's whatever it is, whatever that change is, we would make the appropriate change. So I really think, like Marie said, we want quality of life to almost be represented like a vital sign. And it's really the vital signs of that household, or the vital signs of that family.
Well, I think I can speak probably for our entire audience that everybody's really excited to hear more about this tool, and it sounds like you guys are doing some amazing work. So is your plan to eventually, once you've done research on this tool, make this available?
Yes, for sure. So we have already validated our tool. So there will be a publication coming out in the near future to describe how we developed the tool. Anyone who's interested in using the tool for assessment purposes or for research purposes can feel free to reach out to either Dave or to me. We're happy to share the tool. And yes, we are very much looking forward to it being integrated in other centers.
And I like what you said too about the patient or the family filling it out themselves. I think there's some data on self-reporting versus being asked, right? And a patient's answers, maybe it's easier for them to answer something when it's a self-reported tool versus when they're being asked, and maybe there are things that they don't want to talk about, right, directly to their care team. So I think that's a really great feature, it sounds like, of this tool. Have you found that before, the self-reporting versus the patient being asked in clinic, like in terms of differing answers or not?
So we haven't done any analyses to try to identify whether there are differences in sort of timing or mode of reporting. One of the really interesting things we are finding, and this is actually consistent with the research in this field and also in other disease states, is that the way children report on their quality of life is quite a bit different from the way that their parents report on the child's quality of life. So that'll be interesting for us to explore kind of as we move forward. But I think it all goes back to really making assumptions and sort of perspective, right? And who we're asking and the questions that we're asking to try to better understand this super complex concept.
Okay, one more question for you guys, and then I do want to address a couple of questions that are in the Q&A. So, really, are there any other patient or provider tools that you want to kind of share with our audience today on this topic to either help them learn more, or right, if they have questions that they want to refer patients to or learn themselves?
Marie, will you take that?
Sure. So again, we are happy to share our tool. So that is one potential resource to the community. I also suggest or welcome any of the audience members, whether you are a clinician or a patient or a caregiver, to look up some of our published peer-reviewed research, which really the cool thing about this work really is that it's co-authored by clinicians and also patients and caregivers themselves. So we've really worked hard to integrate perspectives of the people who are ultimately living with this condition every single day into every single one of our outputs. So I would welcome anyone to look at those as additional resources. And then one additional resource that I would like to share that I was part of the development of, and I think we can share it in the notes of this episode, is a transition of care guide for pediatric SBS patients. And it's really designed for caregivers, but also for patients to use on their own to really guide patients and families through many stages of transition from, the diagnosis stage to then entering school, becoming an adolescent, and the very many sort of transitions that we all experience. So I think that would be an additional guide that might be helpful, especially for patients and families.
Great. Well, this session is being recorded today and will be posted on YouTube in the next 48 hours. So we will link those items that you mentioned, Marie, in the description of the video for our audience to be able to refer back to. Okay, so there's a couple questions about the tool specifically. So is the tool that you guys are developing specific to SBS, or can it be used in really any HPN patient?
Thank you for that question. So the tool is specific to pediatric patients with a history of intestinal failure. So parenteral nutrition dependence is not one of the criteria for eligibility to use the tool. It is desired to sort of be holistically relevant to that particular patient population, but it is specific to peds and not adults.
Which isn't to say that, in the end, when you're doing a project, you have to pick one project and just work on it. And this is where Marie's expertise and her heart was. I can tell you that going through the same iterative process, we could develop a very similar process in adults. It's just a matter of time and manpower and everything else. And I think we would want to choose the same approach where, I mean, this was truly, it had nothing to do with me in the development. It wasn't Dave Mercer saying, here's how we should assess quality of life. It was literally Marie, children, and parents figuring this out, doing all of the development solo. And I think we would want to follow a similar process in developing an adult tool.
Great. Well, there was a question in our Q&A on whether it could be used in adults. So you guys have already addressed that, and it definitely sounds like it's something that our audience would be interested in. All right. Well, this will now conclude our session today. Thank you all for participating in today's Nutrition Nexus Live program. Thank you to our wonderful speakers, Dr. David Mercer and Marie Neumann, for sharing your expertise with us today. And a special thank you to Zealand for supporting this program. Have a great day, everyone.
Thank you.